Americans awakened on January 1st, 2000 with a collective sigh of relief as alarm clocks, computers, and other technologies successfully navigated the leap to Y2K. In the first decade of the 21st century, America would witness the first African-American president, the first handheld music library, and the first Austrian bodybuilder to become the governor of California. Pink was mad, reality TV was the fad, Florida couldn't add, and Donald's hair was just bad. Healthcare was dramatically impacted by some of the worst disasters in American history, some of them natural and some of them not. Ideas about biomedical technology, electronic medical records, and the healthcare share of the GDP were growing. But so were workforce shortages, healthcare costs, and MDROs. While celebrities were dancing with the stars, Arjun Srinivasan, Sanjay Saint, and Denise Murphy were targeting zero healthcare-associated infections, and much like those who came before them, were having a profound impact on the effort to make patients safer. Arjun Srinivasan has conducted groundbreaking research in the areas of outbreak investigations and multi-drug-resistant gram-negative pathogens and antimicrobial use. In 2008, he assumed the medical directorship of the new CDC campaign called Get Smart for Healthcare, which is designed to improve the use of antimicrobials in patient healthcare facilities. Currently, Dr. Srinivasan is the Associate Director for Healthcare-Associated Infection Prevention Programs at the CDC, where his primary responsibilities include oversight and coordination of efforts to eliminate healthcare-associated infections. His research and investigative areas of concentration include outbreak investigations, infection control, multi-drug-resistant gram-negative pathogens, and antimicrobial use and resistance. Sanjay Saint is known for his research on enhancing patient safety by preventing healthcare-associated infection, translating research findings into practice, and medical decision-making, including cognitive errors. He has authored over 200 peer-reviewed papers, with over 60 appearing in the New England Journal of Medicine, JAMA, or the Annals of Internal Medicine. He has been a visiting professor at over 35 universities and hospitals in the United States and around the world, and has received several major teaching awards. Dr. Saint is a professor of medicine at the University of Michigan Medical School, director of the VA University of Michigan Patient Safety Enhancement Program, and a liaison to CDC's Healthcare Infection Control Practices Advisory Committee. Denise Murphy entered the field of infection prevention and control in 1981 and has been an epidemiologist in hospitals ranging from 100 to 1,200 beds in rural and urban settings. She is nationally and internationally known for her presentations and publications on establishing or redesigning infection prevention and patient safety services in the business of infection control, patient safety, and performance improvement. Ms. Murphy was APIC president in 2007 and recently led the development of the APIC Infection Preventionist Competency Model. Ms. Murphy continues her impact on infection prevention as Vice President for Quality at Mainline Health System in suburban Philadelphia and remains active in futures planning, leadership development, and global business strategy for infection prevention. The turn of the century brought with it new developments in television, style, and technology, among others. By the end of the decade, the threats of Y2K were starting to sound funny, but Denise Murphy, Sanjay Saint, and Arjun Srinivasan were on the front lines, ensuring that patients would be even safer by Y3K.
Awesome. Our 2000 decade difference makers. Arjun, I wanted to ask you, you've covered a number of areas in your career, and I'm wondering if you could share with us the growing connection between CMS and how it is impacting infection prevention.
Yeah, absolutely. You know, I think the decade of the 2000s saw a dramatic expansion of federal involvement in healthcare-associated infection prevention. You know, CDC had been in this for a very long time, but in the 2000s, you know, we really saw this growing national awareness, finally, that healthcare-associated infections were preventable and, in fact, unacceptable. And there was a greater and greater call on government entities to take a more active role in trying to enforce prevention of healthcare-associated infections. We saw the advent of state reporting mandates early in the decade. We saw consumers find their voice on the unacceptable nature of healthcare-associated infection and demand action from the government. And towards the end of the decade, we saw these transformative events happening at the federal level. The Government Accountability Office does an investigation in 2008 and calls on the federal government to enhance its coordination and oversight of healthcare-associated infection prevention, led to the development of the Health and Human Services HAI Action Plan, which was launched in 2009. And that action plan then became the foundation of the inclusion in healthcare-associated infections within the Affordable Care Act. So with the passage of the Affordable Care Act, the Secretary of Health and Human Services was ordered by Congress and the President to implement the HHS Action Plan, to take concrete steps to prevent healthcare-associated infections. And of course, that inclusion into value-based purchasing is what set the stage for the environment that we live in now, where healthcare-associated infections are publicly reportable at a national level on Hospital Compare. We're anticipating the development of pay for reporting and pay for performance with healthcare-associated infections. So these major transformative events that happened in the 2000s that I think changed the practice of infection prevention forever. I think we now live in a climate where infection prevention is more difficult to practice than it's ever been before. All of us are called on to meet new regulatory requirements that we have never had before, expanded reporting of healthcare-associated infections, demands for outcome. We're called upon to do all of that under pressures that are vastly different from anything we've had before. The number of interested stakeholders in what we do, the number of people who demand action, who want to know what we're doing and how we're doing it, is greater than ever before. So we're in a more challenging environment than ever before, but I would argue that we're also in a setting where the field of infection prevention is more important than it's ever been before.
Yes.
The nation and all of our patients are calling on all of us to guide the implementation of these mandates. It's fine to pass these regulations, but how do we implement them? How do we define infections? How do we find infections? That's us. We tell people how to do that. It's fine to have numbers for infection rates and standardized infection ratios, but what do those numbers mean? How do we use those numbers to guide prevention efforts? That's us.
Yes.
It's fine to talk about preventing infections, but how do we prevent infections? That's us. So I would argue that this is the time for us, for infection prevention, to redefine our field and to take this challenge that's been issued to us and to move it forward into the next decade.
Now, you actually have another area of focus that we heard on the video about antibiotic resistance and the multi-drug resistant organisms that are in all of our environments.
Right.
Could you just tell us briefly a little bit about that?
Absolutely, and I think that's the other area that's really transformed our field in the last decade. The 2000s were the era where MRSA became a household word, and now people are aware of carbapenem-resistant Enterobacteriaceae, CRE, and NDM enzymes. And I think there's an awareness now that we're running out of antibiotics. We're running out of treatment for infections. So if you run out of treatment, what's left? Prevention. So now it's upon us. We now have the responsibility for tackling these multi-drug resistant organisms. If we don't prevent these infections from happening, if we don't do what we know works, if we don't find new ways to prevent the development and spread of these organisms, we are going to be in a situation where we can't treat infections and we have to stand by and watch our patients suffer and die from infections that we know we can prevent because we can't treat them.
Wow. And Sanjay, it sounds like you talk about how patient safety started at the beginning of the decade. It really became that hot topic. How did that patient safety movement impact infection prevention? If you could expound on that a little more.
Sure, happy to, Kathleen. Well, November 29th, 1999 was a very important day, and it's when the Institute of Medicine released its report To Err is Human. And in it, the IOM estimated that up to 98,000 Americans die each year because of patient safety-related problems. Galvanized public attention, and even though, as Dr. Mackey said, the people in infection prevention had been focusing on patient safety, this now got the public's attention. But what's interesting about the IOM report, even though it was 223 pages, essentially only 2 pages were devoted to infection prevention. And those 2 pages were in Appendix E, as in easy to overlook. And as the decade progressed, things changed dramatically.
Yes.
Because even though the IOM report had only about 1% of its pages devoted to infection prevention, when you look at the major patient safety initiatives, the 100,000 Lives campaign, the CMS Do Not Pay list, and now the healthcare engagement networks, between 1/3 and 50% of these patient safety initiatives include HAI prevention. So, in fact, Bill Scheckler wrote in 2002 that infection prevention is the paradigm for patient safety, arguing that using standardized definitions, surveillance, benchmarking, evidence-based practice, and making sure those are used in everyday practice is what quality managers should also be doing to prevent non-infectious complications, such as DVT, falls, and delirium.
Well, I actually do get around the country a bit and to a lot of hospitals. And what I'm trying to figure out is, why are there some hospitals that really rock and nail the reduction of healthcare-acquired infections, and then there are others that are massive, and I'm sure you see this, are massively struggling with this. Could you comment on that?
Yeah, we've been trying to answer this exact same question as well, Kathleen, and a lot of it has to do with implementation science. I know that term has been used often this morning. It's an important one because it's also a science that emerged during the last decade. And it's a scientific study of trying to figure out, how do you go from the published literature and evidence-based guidelines and actually make sure that every patient gets what they should be getting. And what we have found is that there are some things that help implementation and help make sure that hospitals are doing what they're supposed to be doing, and other things that hurt those things. And fundamental to this is understanding that implementation consists of 2 key components. There's the technical, which would be the evidence-based guidelines, and then there's the socio-adaptive, which is the art, as Patty mentioned this morning. This is understanding how to change behavior, understanding the context and the culture and the microculture. And what we've seen is that what helps move things forward are collaboratives with leadership support, identification of committed champions, IPs, bedside nurses, healthcare epidemiologists, and others, using bundles and checklists. But on the flip side, there are barriers to using evidence-based practices. And what we found is that there are certain individuals who are active resistors, that they do things the way they've always done. Why? Because it's always been done that way. And it tends to be surgeons and anesthesiologists, but
Yeah. Let's just put it right out there.
And the other group of individuals at hospitals that we've also discovered that prevent the use of evidence-based practices are organizational constipators.
That's a great name.
Mid-level to high-level individuals who say the right things at meetings, but when push comes to shove, they don't do what they need to do to move things forward.
Yeah. Absolutely. And what you talk about, it's really about the culture of what we create in organizations. And Denise, my understanding is you've created a term called people bundles. And I'm wondering if you could expound on that a little bit.
Sure. So before I talk about people bundles, I just want to say that I have been blessed to be a member of so many incredible bundles of people. And so to those of you in the audience and those of you that are not here, I thank you so much. The people bundles are simply a compilation of safety behaviors and tools that help enforce those safety behaviors that really are intentionally aimed at the prevention of human error. So for example, behaviors might be pay attention to detail or speak up for safety and question and confirm. But tools to really help you speak up for safety are things like stop the line. So you see an empowered member of a healthcare team. It could be a unit secretary. It could be anyone that's seeing someone during a line insertion not use all of the elements of the evidence-based bundles that we have. And so people bundles are just those things that help empower people, but actually the word empowerment is used a lot and it's so important, but I think people need tools to really feel empowered and to be able to change behaviors. So that's what I refer to as people bundles. So in concert with the clinical bundles, in an environment or a culture where that is supported, we have seen organizations all over the country eliminate or nearly eliminate, certainly drops of 50, 70, 80% of preventable harm. And so it really does make a difference. We can't do it with the evidence-based measures alone. We have to really address what makes people create errors or what makes people not be able to comply with safety behaviors.
Yeah, no, that makes sense. And in that concept of getting to zero, we hear that frequently. And it's a big part of infection preventionists' lives, and it's a big part of my life as a clinical nurse specialist. What do you mean? What do we mean by that concept, and how does that fit in? Is it a different kind of culture that's created?
I think it is definitely a different culture. And so back in the 1999 and 2000, APIC invited many of us who were in organizations where the culture was changing. And I remember one time standing in the OR with Stephanie Koenig, an infection preventionist at one of our BJC hospitals, and we were talking about the high rates of infections and what were we going to do to get them down to the CDC benchmark. And Stephanie looked at me and she said, "Wow, do you think anyone wants an infection? You know, should we really be talking about benchmarks?" And I said, "Gosh, no. We really should be talking about zero, but nobody's going to go for that." You know, so that was, and then the language and what was more important is the evidence started to take hold. So across the country, people were seeing 18 months with no CLABSI. They were seeing 20 months with no sternal wound infection. And so we started to talk about it, but the language created conflict. So to the point that Patty Grant made this morning and that wonderful comment, thank you for sharing that, Patty, about conflict can lead to good things. The language creates culture, so we had to get the language right. But we were talking back then about zero tolerance.
Right.
And that created a lot of fear because people were afraid that zero tolerance for infections, it could end up in a punitive response from governmental agencies, accreditation agencies. So we pulled together in 2007, APIC, SHEA, CDC, the Joint Commission, the IHI, and many other groups to really see if we couldn't come up with a unified message. And what really turned the conversation for us was Dr. John Jernigan, who is from CDC and on the call with Denise Cardo. And he said, "You know, why are we so afraid to use the word elimination? If we didn't use that word in the context of tuberculosis or HIV/AIDS, where would we be today?" And I'm telling you, that really, really turned the whole conversation to targeting zero, not focusing on benchmarks, but targeting zero is absolutely where we have to go as a country and really in the world.
And so let me ask, from the healthcare practitioner perspective or the infection preventionist, how easy was that concept of elimination because there's this sense of ownership that I own infection?
Right, exactly. So a couple of culture changes here, and I'll just digress for a moment to a couple of early culture changes. In the early 2000s, we started talking about two things that were very different. We had our own culture in infection prevention and control. We were the data experts, right? And so we started challenging people to do two important things. One was to make the business case for infection prevention, to start to speak the language of healthcare executives and to talk about infection prevention in the context of the business of healthcare and to really convince executives why it was so important to invest in infection prevention. Many, many people across the country and across the world did that very well, got more of an investment, more resources, more focus on the important work of prevention. And because of that, those early leaders started to see zero infections. We had trouble believing it. And so we started seeing it happen everywhere. People stepped up to the plate, they began publishing it, and more people started to believe it. But the controversy continued. And I think why targeting zero is the language we fell on was because we know that we may not be able to eliminate every infection, every type of infection in every setting for every patient forever, but we can get infections to zero. We can sustain them for very long periods of time. We can empower our healthcare teams, and Sanjay talks a lot in his writings about leadership versus followership. And another big culture change for us as infection preventionists was to watch the other members of the healthcare team start to own infection prevention, and suddenly we were behind them. We were following them, but in our hands were the knowledge, the tools, the data, and the evidence. We were translating the research into knowledge at the bedside, and we were handing it off to them. And so there was the different partnership, and I think that incredible belief that as a team, we can really do this together. So I think that's been the message throughout the whole conference. It's really in all of our hands, but so much culture change has occurred, and it's been frightening but incredibly successful. So I thank all of the leaders that have made a difference and all of the people in the audience who are about to continue to move that forward.
And there is no question that the difference makers of the 2000 have made a huge impact in the direction, in the right direction, that we're moving forward in our clinical environments for our patients and for ourselves. So I want to thank you so much.